Good morning, dear friends. Welcome to this EUDF organized symposium co-sponsored by the WHO Regional Office for Europe on enabling high-quality diabetes care by setting targets, monitoring data, and initiating action. I am Chantal Mathieu, and I want to introduce to you EUDF, the European Diabetes Forum, very briefly. We started this as ESD and EFSD together with the Federation of Endocrine Nurses and then JDRF, now Breakthrough T1D, 6 years ago, because we realized that it is very important to speak with the harmony of voices of all stakeholders involved when you talk to politicians in Europe, but also in your own countries. And so very rapidly, we were joined by other societies, including the International Diabetes Federation Europe, ISPAD, the International Society for Pediatric and Adolescent Diabetes, Primary Care Diabetes Europe, and also Société Francophone du Diabète. What is important is that all these stakeholders come together representing clinicians, academics, researchers, but also, very importantly, people living with diabetes. And also we wanted to have industry on board. We wanted to hear their voice too, and we invited them to be supporting collaborators, and you can see the membership there. EUDF wants to work on different topics that are put forward by the different stakeholders, and so we have different spearheads, different strategic fora, as we call them, where we get together in groups. Some of these fora have already put out white papers or official publications. And today, our session fits in the realm of the forum on data and registries. What we really want to do is to enable healthcare systems to cope with the diabetes pandemic while achieving the best outcomes for people living with diabetes. And as said, we want to induce policy actions. Now, have we been successful? I dare say yes, because we do have the ear of members of parliament in Europe. We do also have the ear of the Commissioner of Health, Mr. Várhelyi, who we met several times now and who really is attentive to everything we put on the table concerning diabetes and the importance of this disease. What is important is that we also have a privileged partnership with the World Health Organization Regional Office for Europe, represented today by Dr. Jill Farrington, and this has been very fruitful. For instance, they have put forward targets for specific outcomes in diabetes globally as WHO, and we as EUDF have proposed specific translated targets for Europe, which you will see later on in the symposium. Now, what is important is in Europe, healthcare is in the countries. It's in the member states. And you can indeed induce a statement, you can induce a direction, a guidance at European level, but the countries need to implement it. And so what we did from the beginning is stimulate the creation of similar fora with the name of forum or not, but similar fora in different countries where different stakeholders come together, the clinicians, together with the people living with disease, and also bringing industry to the table, because to me they are also crucial in discussing fair access to novel therapies or tools helping people living with diabetes. And we will have another symposium. When is it, Bart? Tomorrow evening, on different examples from different countries, how these different regional and national fora can exist. And here you can see some examples of existing forums like the Belgian, the Romanian, the Italian, also in France this role is taken up by SFD, and also the Greek people coming now together for the first time under the chairmanship of their Minister of Health. So without further ado, let's dive into the topic of today, namely the importance of setting targets, gathering data, monitoring these data, and initiating action. And so I hand over now to my colleague, the president of EUDF until a couple of weeks ago, and that is Professor Stefano Del Prato, on the use of data to raise awareness and initiate action to improve outcomes. Stefano.
Thank you very much, Chantal. I think that we can move on here. Now, registries. When you come to registries, you may think registry is something relatively new thanks to the technology. However, the discussion about registries started some years ago. This is a paper that's been published in 1973. It's a review on the possibilities, on the use of the registry, and so on and so forth. Maybe a different view for what we consider now the use of a registry. But besides what is written here, what I really like about this paper is the final words, and they were not the words of the authors, but actually the words of Thomas Eliot. And those words are saying, what is the wisdom we have lost in knowledge? And what is the knowledge we have lost in information? So underlying the need to collect the right information to really be able to gauge what we're doing with people with diabetes. And I would like to give you a couple of examples of what the information can provide in terms of really improving the care of people with diabetes. And I like very much the experience that Juliana Chan has established in Hong Kong. The idea was really to have a registry collecting information from all the different stakeholders involved in the treatment of people with diabetes. Of course, are the doctors with their ability to diagnose, treat, taking decisions, and so on and so forth. Is the non-physician staff with their engagement and empowerment. And then, of course, it's also needed to take into account what is the availability in terms of finances and resource. And all this is brought together, linked to the medical record, the electronic medical record, to define benchmark, and then to identify gap. And on the basis of that, evaluate through the registry the quality to improve the stratification of the risk, to address personalized care, and to empower people living with the diabetes with a final goal. And the goal is the usual goal. The goal is a goal of improving the outcome, improving the overall risk profile of people, to evaluate the process, so improving the process itself based on the data that are generated through their collection, and then to monitor the trend. Now, is this going to work? Is this providing anything that is very effective? This has been the change over the years upon the implementation of this registry in terms of the event rate for the leading cause of impoverished quality of life in people with diabetes. You can see here CHD, stroke, heart failure, hyperglycemic crisis, and so on and so forth. So you can appreciate that all of them have been reduced in a dramatic manner. And this just on the base of generating treatment or process of treatment based on the result and based on the collection of the data. There are different ways to collect the data. I'm from Italy, so I'm going to report a little bit of experience from Italy, which has been actually recently taken up by the WHO, and is related to the data that the Associazione Medici Diabetologi from Italy have been carrying out over the past few years. What has been used was an automated data extraction from the electronic health records in Italy. And just to show how this collection of data can allow an assessment of the quality of care by generating a score, and to appreciate, how that score of the quality of the treatment may change over the time. And you can see here an example. But this is, of course, it's not all we have. There are many other registries available. This is just a couple of examples, but I think these two examples here highlight the potential for a data registry. Registry indeed may provide benefits from many different stakeholders in the diabetes landscape, and they can accomplish the goal of improving the quality of care through multiple processes and by collecting multiple data. You can agree with me that by and large, registry can represent and define the benchmark for the treatment. It may improve the quality of care through monitoring, surveillance, and healthcare planning. It may help in empowering people living with diabetes. It can generate real-world evidence that are becoming more and more important, making all of us investigators and researchers, and of course also foster research. But there is another thing which I believe is very important in order of collecting data, and proper data, and polished data. Data are becoming essential for training AI. Without proper data, all the electronic system or the clinical decision support system that we're going to use may be fault because of the poor data. So data is becoming critical also in the future tools that we'll be using for treating people with the diabetes. In spite of that, the uptake of registry is not that homogeneous. You can see here Europe map showing you all the different registries or where the registry are currently available. And you can see there is a lot of differences here, which also pose the question of how we can homogenize this collection of data and how can we exchange these data for proper analysis. It is for this reason that the UDF, on its initial activity, also had a group working on the diabetes registry. It was back in 2022 that a recommendation had been issued on building and maintaining and utilizing registry, and also discussing and providing suggestions concerning the governance, the data collection, and the structure and the scope of the registry. And these were the main recommendations that have been distilled down. One was to develop the right procedure and governance and models for registries to ensure robust coverage and complete data flow. Again, we go back to the quality of the data, maintain flexible and adaptable registries, and develop implementation strategies based on this data collection. UDF also has been very much concerned about this issue, to the point that last year, in the occasion of the annual meeting of the ESD in Madrid, convened a meeting inviting all representatives of countries where a registry is available. It was back in September 2024, and the idea was really to go through what is the current limitation of the existing registries in Europe, just to find out, what is the coverage and the frequency of the data collection, to which extent we fail in capturing the full range of people with the diabetes, and then to which extent the standardization for data collection exists. And this has been has generated a document, and if you may be interested in the document, you can see here the website page where you can download this document. The document and the discussion actually back in September last year also wanted to identify potential challenges, because if we could identify those challenges, we may have better way to design a process to really set up a registry, and potentially to set up registries that can talk to each other across the different European countries. And this, unfortunately, is a long list First of all, is the political will. Of course, we can decide to put up a registry, but we needed to discuss that with the people who have the power to really launch it. It is regulatory procedure. Think about privacy, just to give you an example. Is the digital infrastructure, of course, data registry, particularly the modern data registry, particularly if you think of linking those data registry with AI development or AI training, requires specific digital infrastructures. And people working in the registry need to receive incentives, of course. And I think this is an important point. We need to increase awareness of the importance of quality data. I'm a physician. Sometimes we're rushing all the time, through our clinic. And when we have to collect the data, maybe we skip that phase. So we need to think to really elaborate on the awareness of the importance of the data, and maybe to think of alternative way to feed the registry with the data. And through that way, we could also think about the real-time data that are directly and automatically feeding the registry. I already been touching on the data quality. I already explained to you, at least to my view, why the data quality is important. Of course, it's important for the person living with diabetes, but also important to set up a system that can assist us to provide the care. And finally, we need to make the right use of the data, but that will be open to our ability to really identify questions and problems that can be solved by interrogating this data. Data quality is important, and the data quality also refers to the data that we are collecting. Which data do we need to collect if we want to establish a registry for people with diabetes? We need here to have some sort of a consensus. An attempt to that consensus has been initially provided by the HICOM standards. By the way, some of these standards have been already adopted by some registry. You can see here on the bottom of the slide the countries that have been using these items for the registry. And this data refers to the diabetes control, to the record of acute events, of course, to the assessment and monitoring of the survival and the different cause of death. It's important also to collect patient-reported outcomes, monitoring the chronic complication, and we also needed to embed that into the environment, and most of the time it is financial and organizational environment that we needed to take into account. The group, so overall, the impression out of the meeting that we had, as I was saying before, last September, is that registries in Europe do exist. The problem is that not all of them, collect the same data, or collect the data in the same way. So the main question here, at least at a pan-European level, is how we can then compare different registry map and understand data available through them. So this is one important step forward that we probably need to take into account. And what has been proposed by this group at the end of the very intense discussion is that what we need is to define the data architecture and to share that architecture through the different countries, to define data standards. I've been touching on the standards just a moment ago, but of course we can discuss what is important, at least to my eyes, that we come to a shared and agreed way of collecting and which data we want definitely to be collected, and then to define these items to be collected. The final goal is to build up a map, potentially not just a country-level map, but possibly an European map that is based on this data, that may inform about the epidemiology of the disease, that may that allow monitoring the clinical result and to gauge that result with respect of the effort that has been paid to achieve that, result. And when I'm saying effort, I also referring to the manpower required, the financial effort that is required, to the organization that has been set up, to identify the risk factor, the prevalence, the health outcomes, comorbidities, and quality of care. Nothing new if you think, but what is important here is just to have an homogenized way to really build up this map. Now, this result of this discussion have been condensed lately in a paper that Chantal and myself, on behalf of the EUDF and EUDF participants, have published. This paper has been appeared in the Lancet Regional Health Europe, and the main conclusion is that with a high-quality diabetes registry, we can better examine the type and standards of care the person with diabetes receives. Many diabetes registries are currently unable to consistently provide information on monitoring and managing diabetes, and standardized outcome definitions and data collection methods are definitely needed to compare outcomes and subsequent improvements. So this has been the position of the UDF, and I will stop here and I hand it over again to you, Chantal. Thank you.
Thank you, Stefano, for setting the scene. So we need to collect data, we need to use registries, and we need to have them of high quality. We know that Europe is doing a lot of effort in their health data space to indeed push countries to collect data in a structured manner so that exchanges will be possible. But data alone is not enough. A registry alone is not enough. I think it was also one of the topics of a symposium by EUDF. We also need targets. We need to know where we want to bring the level of our diabetes care. And so to discuss, can I have the next slide for Dr. Farrington? To discuss this topic, namely the targets, I invite Dr. Jill Farrington, the Regional Manager of Diabetes and Cardiovascular for WHO Europe, to join us here on stage. Jill.
Thank you so much, and wonderful to be back again. I was privileged to be involved in a symposium on registries last year, and I can also update on some of the work that we've been doing since then. What I want to do is to talk about the targets, and also from the perspective of WHO about monitoring data and how we hope that it leads to action. Just a few words about WHO, because it's not always clear in a room of clinicians what it does. So the World Health Organization is a specialized agency of the United Nations. Our governing body are the ministers of health of the member states, the countries. So we have direct access to policymakers at the national level. And we meet with those policy makers on regular intervals, but particularly at our general governing bodies, which is the World Health Organization in May, and the Regional Committee for Europe, which will be taking place at the end of October. And there we will be discussing our new program of work for Europe. And importantly for Europe, when we talk about the European region of WHO, it's covering 53 member states, stretching from the Atlantic to the Pacific, Europe and Central Asia. In terms of targets, many targets have been set by WHO and endorsed by member states. These are the targets which may be quite familiar to you by now, which are the NCD targets to be achieved by 2025, which include one on halting the rise in diabetes and obesity, which we'll be reporting at the UN high-level meeting in New York shortly. There's also diabetes as part of the targets that Sustainable Development Goal Target 3.4 about reducing premature mortality from non-communicable diseases, diabetes being one of those major non-communicable diseases. And there are also the more recent global diabetes targets set in 2022 to be achieved by 2030. And I'll talk about those in a bit more detail in a moment. WHO has also been quite strong on the importance of monitoring data for diabetes care, prevention and care. And I'll just run through some of the key documents that have been mentioning that. So the Global Action Plan, which was endorsed in 2013 and runs now until 2030, has a whole pillar which is around the importance of monitoring trends and determinants of non-communicable diseases and evaluating progress in prevention and control. The Global Report on Diabetes, which was in 2016, shortly to be renewed, also talks about strengthening national capacity to collect, analyze, and use representative data on the burden and trends of diabetes. And then there's the Global Resolution at World Health Assembly on Diabetes in 2021, which is recommending to strengthen and monitor diabetes responses within national NCD programs. And you'll notice that diabetes registries are specifically mentioned in the first couple of documents, but it is doing so recognizing that they may not always be feasible and sustainable in the setting that they are in. And this will link to some of what Stefano has mentioned around perhaps the resources needed to set up and maintain a registry. Other relevant documents around the monitoring data, the HEARTS-D is the simple protocol on diabetes care, type 2 diabetes care in primary health care in low middle resource settings. That is also stating the importance of a monitoring system to assess the effectiveness of management and complications occurrence. And it sets forward a set of indicators which are then expanded within the later 2022 guide on facility-based monitoring. These all come together in the document that came out last year, which is the Global Monitoring Framework on Diabetes Prevention and Control. And that really is trying to collect together a whole range of different indicators, both for prevention control in healthy populations, or the general population and the population with diabetes, and going through determinants, risk factors, service delivery, outcomes, and impacts. WHO monitors what is happening in member states and uses a range of different instruments to do so. Every 2 years, we have a country capacity survey where we contact the ministries of health in all countries and ask them a whole series of questions about the policies, guidelines, other instruments that they have in place. I'm just giving one extract here because this is our most recent data from the last survey in 2023. And that was showing that within Europe, around 2/3 of countries said they had a registry, of which 30 said it was at national level. But just this yes, no type answer doesn't really give much information on the quality. And as we've already heard, they can vary quite a lot, also in terms of scope and purpose. So in some countries, they may be quite limited, held by the Center of Endocrinology, focusing on children with type 1 diabetes. In other countries, they can be automatic extracts from electronic health records, for example. Talking now a bit more about the global diabetes target. So this was something that arose from the 2021 resolution and was endorsed in 2022. And these are 5 coverage targets. So these are not intended to be individual treatment targets. These are looking at the kind of population of people with diabetes and have been chosen to focus on detection and treatment, and trying to highlight which are areas of missed opportunities around diagnosis and treatment, drawing attention to gaps within and between different countries. So just go through them. The first one is around diagnosis. 80% of people with diabetes are diagnosed. 80% of people with diagnosed diabetes have good control of glycemia. 80% of people with diagnosed diabetes have good control of blood pressure. 60% of people with diabetes 40 years or older receive statins, and that 100% of people with type 1 diabetes have access to affordable insulin and blood glucose self-monitoring. And we're often asked, why is it not 100% on everything? And a country has the freedom to set it at 100% if it so wishes. But these were set at the time according to what the best performing countries were achieving. So the work that we were doing during 2024 was trying to work with a number of countries in the European region to see how would these targets be measured and what were countries finding. And we wanted to look in the real world with the data that countries have available routinely, how would they measure themselves against these targets, and then how would they follow through on those targets and bring progress. Because as we've said, it's not just about monitoring data, it should be leading to action. So we started off in April with an expert meeting. We invited all ministries of health to participate. We had a number of meetings with them, working through how it could be measured. We promoted at the European level through different bodies the importance of setting targets and monitoring them, and then we published our results. These have already been alluded to. So we had 13 countries that self-assessed working with us. We had 8 countries that worked with us to produce more detailed case studies, and then we came up with an overview of the key learnings from that exercise. Stefano's already shown some from Italy. We'll hear from Belgium later, and I will also highlight 2 other countries. But first, the kind of overall results. So I'm showing here the first 4 targets. From left to right, targets 1 to 4, the median and the range that we got across the different countries. And if you can just see them, the little blue dots are each individual country. And the red line is where the target should be. So we could find that of these 13 countries, which is 25% of the European region and quite a representative sample of high, medium, and lower income countries from all parts of Europe and Central Asia. So we found that almost all of them could measure the targets. We found that to do that, a variety of different data sources needed to be used. Target 1 could only be measured by a health examination survey because it needed to be able to capture those people who were not yet identified as having diabetes, these sort of known and unknown people with diabetes within the population. We found there was also a very wide range of results. You can see the stretch of the box plot and the blue dots, and this was particularly so for the 4th target, where there was a 10-fold difference between countries. And then we found that even if we just look at the median, only one of the only one of the targets was being reached for this sample overall, and that some countries were meeting some, but not all, and some were meeting none. And then the target 5, which I'm not showing because it's a slightly different measurement process, was being fully met in 5 of the 13 countries. And I have to say these results surprised us, because when we began this process, people were saying, well, we're Europe, why have you not set the targets at 100%? Of course we can achieve this. Look how good our care is, look how good our data is. But when we actually delved into it, we found we were doing less well than we thought we would be doing. In terms of some of the key learnings, these are explained further in the report, and some of them are similar to those which Stefano has said. So we did highlight the gaps in care, as I said. Some countries doing well, some countries not doing well at all. Some countries surprised with the gaps that they were finding. Also gaps at local level. It might look good overall, but they could see quite a lot of differences at the subnational level. Inequalities in health, I'll show you a few examples on those differences between different subpopulations. We found good examples of data being used for advocacy purposes to bring about change with clinicians, with politicians, to argue the case, showing the gaps, saying we need to do more. Patients' associations involved in reviewing that data and using that data. Issues of data governance, as have already been mentioned, access to the routine data and linking different sources of data, because in this we were often using a health survey, which was coming from the kind of public health institute or public health people, the registry or the clinical records, which the clinicians or associations had, and then potentially other sources, and then trying to bring them together. Adaptation to national context, some countries already had tighter targets that they were setting for themselves. And this evidencing assumptions, I've already said, most assumed they would do really well and were surprised with the findings, and particularly around target 5. I think everybody said to us, of course, 100% have access to insulin, but the target is about access to insulin and devices for self-monitoring, and that we went further, we were discovering that there were co-payments, not everybody had access to what they needed in terms of the different devices. The data and surveillance methods, I've mentioned some of those already, multiple approaches and data sources needed, and some of the strengths and weaknesses. If we look into a couple of the examples, so Finland, high-income country, around 5.5 million. And so in Finland, they had got a data registry which was automatically collecting data from multiple national resources, a patient data repository, as well as prescription center, benefit register, population information system. So they had a sophisticated system, and they also had a regular health examination survey. And you'll see that in terms of the results, they needed to use both of those sources of data to measure the different targets. They were not achieving all of the targets in Finland. The one that they appeared to do worse on was the one around the blood pressure control of people with diabetes. In terms of some of the lessons learned, they were able to demonstrate differences at subnational level. So the graph is showing differences in glycemic control between the different well-being service counties in Finland, between those who had a higher proportion of patients with poor glycemic control to those who had a lower proportion of patients with glycemic control. And even though they had a sophisticated data register system, it did have limitations. So only 40% of patients with diabetes have blood pressure measurements available in the National Data Archive. And so it wasn't suitable for measuring that target 3, and they had to resort to the health examination survey for that. Tajikistan, if we another part of our region, and we take one of the lowest income countries within the European region, 10 million largely paper-based records, national benefit package, but also high out-of-pocket spending, which can limit access to medication and testing. In that case, for measuring the targets, they largely had to use a health examination survey. In fact, that's what they used. They could check against other reviews of clinical audit of patient records for kind of triangulation of what they found, but essentially they were dependent on the STEP survey. And in their case, although they could measure all 5 targets, they found they were not achieving any of them. Even so, with the health examination survey that they had 2 time points on that, and they were able, 2016, 17, and 2023, so they could show trends over time. And they could also show differences. So this was the proportion of people with diagnosed diabetes who have good control of glycemia and the differences between men and women. So in finishing, the key messages, I mean, the WHO, working with member states, has a set of voluntary global targets which are relevant to prevention and care of diabetes. And through numbers, I would say all its documents, but I've shown you multiple documents where it's promoting surveillance, health information, the importance of monitoring systems. And it's also put in place frameworks and indicators to support countries in measuring the effectiveness of their diabetes management and prevention. We showed in the European region that it was possible to measure the targets. Multiple sources of data were needed. There was wide variation between countries, and frequently the targets were not achieved, even at the sort of European level sample, as well as within individual countries. But we also found the process of doing that extremely useful. During that time of working with the different countries, as we were asking for what data, it was sometimes the first time it felt that different groups and different sources of data had come together collectively to be trying to measure these targets. And so we have the outcomes of the initiative, but the process itself was useful. And ultimately, what we've tried to do is to highlight those gaps and then feed that information into the further work that we do with countries in improving diabetes care and empowering populations. Thank you.
Thank you very much, Dr. Farrington. And I forgot to welcome also the people online who are attending, and I forgot to mention that you can put questions in the app. If we have time at the end, and it looks like we may have time, we will ask them to the panel, but we also have microphones that you will be able to answer. And also, we will put the synopsis of the symposium with some highlight slides on the website of the European Diabetes Forum. So this is also a repository for many documents that were already pointed to. So now I invite the last speaker of the symposium, and that's Ms. Astrid Lavens. She is a researcher working with Cienzano, a scientific organization in Belgium, and she will present the Belgian case on collecting data and how this allows us to evaluate whether we achieve the targets. Astrid. She's my PhD student.
Yes, so thank you, good morning. I'm Astrid Lavens, and I would like to show you today how our register is built and how we use our data to inform and support healthcare policy in Belgium. So how diabetes care is organized in Belgium, it's divided into trajectories based on the complexity of hypoglycemic treatment and the presence of complications. People living with type 2 diabetes treated with oral anti-diabetic drugs and diet are followed up in the start-up trajectory and seen by the general practitioners. From the moment the patient requires 1 to 3 daily insulin injections or GLP-1 analogs, the patient is followed in the care trajectory, which is a coordinated care between the general practitioner and the endocrinologist in hospital-based clinics. More severe type 2 diabetes patients are followed up in the hospital clinics and followed within the convention. For people with diabetic foot problems like foot ulcers or Charcot foot, there exists a separate convention where the people are treated in specialized diabetic foot clinics. People living with type 1 diabetes are immediately dependent on insulin injections and are therefore, from the time of diagnosis, followed up in either the pediatric convention or the adult diabetes convention, depending on their age. So as you can see, diabetes care is complex. It involves many patients who offer different in symptoms, the type of diabetes they have, the stage of their disease, and the complications they may face. Treating diabetes isn't just about medication. It requires teamwork between the doctors, the nurses, the diabetes educators, and so on. They are followed up in different trajectories seen by general practitioners, specialists, and also the patients themselves gather a lot of data when they daily check their blood glucose monitoring levels. So collecting good quality of data in this setting is a big challenge. So in Belgium, people requiring intensive insulin therapy, whether through multiple daily injections or insulin pumps, are followed up in a diabetes convention. And a diabetes convention is a national care program promoting self-regulation for people with diabetes. It has been set up by the NIDI, it's our healthcare financing and health insurance body, and been set up or existing since 1988 for adults and 1997 for children and adolescents. Through this diabetes convention, people with diabetes receive free of charge multidisciplinary care. And this multidisciplinary team exists of endocrinologists or pediatrician, educators and nurses, dietitians, podiatrists, and psychologists. The people receive diabetes education and material for diabetes self-management, including CGM, insulin pumps, and hybrid closed-loop systems. As a result, nearly all people living with type 1 diabetes and type 2 diabetes requiring intensive insulin therapy participate in this program. Within this convention, all diabetes centers in Belgium are also obligated to collect routinely real-world clinical data from these adults participating in the diabetes convention to monitor the patient characteristics and care quality. So they are obligated to participate in a quality improvement initiative. And this results that at our institute, we have 3 diabetes registers. ICET, that has been born in 2001, ICET Food, that exists since 2005, and ICECAT, which specifically follows the care given in the pediatric convention that exists since 2008. So as mentioned, the Initiative for Quality Improvement and Epidemiology in Diabetes project collect data from hospital-based diabetes centers. In Belgium, we have about 101 adult diabetes centers, 17 pediatric diabetes centers, and 37 diabetes foot clinics. The people that are followed in the convention are the people living with type 1 and type 2 diabetes on intensive insulin therapy. There are about to be 3,500 children followed in the convention, about 70,000 adults with type 2 diabetes, and about 30,000 adults with type 1 diabetes, or 35,000. Routinely, every 2 years, we collect clinical data from the patient at an individual patient level, and these data include data about risk factors, metabolic health, complications, and treatment. Quality improvements is stimulated through audit feedback cycles, and together with, or based on international guidelines on diabetes care, we provide benchmarking feedback to the centers, and in this benchmarking feedback, they see their score for a certain indicator and their position compared to the other centers, which allows the centers to detect improvements in their quality of care and to improve their quality of care where needed. Important to note that this is not a one-off evaluation, but a recurring progress in 2-year cycles, creating opportunities for quality improvement rather than just a data collection. Also important to note is that the work is done in collaboration with a group of experts, represented by endocrinologists and professors of universities, helping to interpret the results, taking the right action, and also translate the results to our healthcare policymakers. Other output is the national report. We also make summary flyers for the patients. We have an interactive ICET tool where the aggregated data are available. And of course, we use the ICET database also for national and international publications. So this is an example of the benchmarking feedback where a center sees its position compared to the other participating centers. And improving quality of care is not just improving the quality of care, but also reducing the variation between the centers. So one of the key advantages of ICET's long-term and recurring data collections is the ability to monitor the targets and trends over time. And recently, we developed this interactive tool, which is reachable through the QR code, where you can follow and discover the ICET data. And if we have a look at the data for the people registered and unregistered living with type 2 diabetes on intensive insulin therapy, and we look at the HbA1c categories, we can see that the proportion of people reaching an HbA1c below 8% has increased from 60% from 2001 to 70% in 2022. Looking at those with an elevated blood pressure, so that's above a 140/90, we see that this proportion has decreased over time. In other words, when we look at the proportion with the blood pressure in target, so below 140 over 90 millimeters of mercury, this proportion has increased from 40% to 60%. We see that also the use of statins has increased over time, and with a peak around 2004. And this aligns with the international recommendations when they started recommending more stringent targets for LDL cholesterol for people living with diabetes. So when we look at the WHO global diabetes targets and whether we can reply or estimate them with the ICET data source, like Gilles already said, we cannot do it with the first target, whether the 80% of the people have been diagnosed, that we can't measure, as we start with a register of already diagnosed people. But about 70% of the people with type 1 and about 73% of the people with type 2 diabetes on intensive insulin therapy have a good control of glycemic control. About 70% of the type 1 and 60% of the type 2 have good control of blood pressure. About 50% of the type 1 and 81% of the type 2 people receive statins. And yes, 100% of our people in our register have access to insulin and devices as they are part of the Belgium healthcare benefit package. So to conclude, 4 out of 5 WHO global targets can be assessed using the ICET data. And although all people living with type 1 and type 2 diabetes requiring insulin do have access to affordable insulin and blood glucose self-monitoring material, the WHO targets are not all met. So good quality, real-world data is essential to monitor progress towards defined targets, assess trends and developments, and support evidence-based policy making. Thank you.
Thank you very much, Astrid and the other speakers. The floor is now open for questions from you to our speakers. So don't be shy, get up, and if you're shy, just put the questions in the app. Dr. Rob Heijnen, why am I not surprised? Well, he chaired the strategic forum. This is Dr. Rob Heijnen from the Netherlands, now working for Lilly, who has chaired our strategic forum on data and registries.
Well, thank you so much, Chantal and Stefan and Jill, actually all the speakers. I really enjoyed this session, so I really want to be complimentary for all the work that the UDF has been doing. So the few observations. If you look at even in the European region, the distribution of the patients that achieve targets, it is still very low with very modest targets, because the targets are not according to the EHD-AD. I think we really need to take that into account. If we really use the 7% and the 130 systolic blood pressure, your results are plummeting. And Stefano made an important comment also from the registries on the political will. Everything we saw during this symposium are because of the champions who are standing over here. Chantal, Stefano in Italy, Juliana in Hong Kong. So in the countries where there's no champion, the results are much poorer. So what's the role of the local champion in achieving these registries and establishing these registries? And where is the political will in those countries where there's no champion? And it is like pulling teeth almost. So are the countries and the ministries of health not aware of the impact of diabetes on their own country? And how can we elevate the excitement, the importance in the countries where we don't have champions? Or do we need to rely on the champions in order to achieve our registries and our goals? So this is my main question.
Stefano, you want to answer?
Robert, thank you very much for this. Yes, is champion, how can we get champion or things rolling on in countries where there are no champions? Yeah. I think that what we're trying to do with the UDF is really translate the model of the UDF to getting all the different stakeholders in the field of diabetes to come together and to really address important issues that needed to be tackled. So I think, and tomorrow night we will have a session for the UDF, inviting in all the country representatives of the local association to present what the UDF is doing, what is the main activities, what the main recommendation, what has been adopted of those recommendations in some of the countries that already adopted a model like the UDF, and maybe trying to offer the support to those countries who do not have the champion to establish a process like that. So I think this is something that we can do on a practical ground. In other words, to really engage as many as possible, not all this big entity of the EUDF representing entire Europe, but just to replicate the kind of model for advocacy and establishing specific processes in the individual country, and hopefully particularly in those countries where no big champions are there. Although I do believe that any country as champion, we need to provide the champion the strength and the support to really stand up.
Exactly. Is that also your experience, Jill, with WHO speaking with all those different countries? Can you see also the impact of the local champion or the political will and awareness of diabetes?
Thank you. I mean, I think I've shown some of what WHO says. So we are actively promoting this issue of setting targets, bringing monitoring data, bringing about change. So that is in many of the things that we're saying. But also responding to your observation. I mean, a number of these countries are health systems in transition. So a number of the countries that we're working with, even within the European region, they have paper-based records. They don't fully have electronic health records. It's important that the clinicians, the champions, are also trying to influence those changes and making sure that things like diabetic eye screening can be well measured, diabetic foot issues, complications can be tracked. So the people with influence in diabetes need to not just be saying we need a registry, they also need to be influencing the broader changes within the system to ensure that routine data will be able to track the effectiveness of care. I think it's also important, it links with that broader issue of quality of care strategies. And again, that's where the diabetes community can link with other communities to be advocating for quality of care measures and tracking those indicators in general. and joining together with other potential champions on that.
Yeah, that's why I have high hopes in the health data space and also the engagement of the Commissioner for Health saying that they will put emphasis on the importance of data being collected and available in a format that will allow data collection, and thus this means also registries. I think there was a second part, Jill, to Rob's question, namely 8% hemoglobin A1C. Well, do we want to continue to call that good control? I mean, my eyes were like this when I saw 80% of all people diagnosed with type 2 diabetes in good control. That's not my experience. But then when you say 8%, yeah. So should we be lowering these targets rather than the percent achieving them?
Each country can lower the targets in many countries.
But if WHO says 8, oh, 8 is enough. If WHO says 7, it's a different signal.
It's a global set of targets which were set on what was achievable by the best of the countries at that time. And in the paper that goes with it, countries are encouraged to be setting targets which make sense within their own countries.
Yeah.
And we found examples of countries doing that.
Yeah, well, you know my opinion. Okay, very good. Please.
I'll keep it quick. Natalie Wisher from Australia. My organisation hosts a number of registries. Our biggest challenge we find with it is the amount of time that it takes doing the audit. How do you incentivise the healthcare professionals to get engaged with the audit and then review the data at the end to make meaningful change and adaptation? I think that's to Astrid.
So Astrid, what is the incentive for the centers to give their data?
Well, first of all, they are obligated to participate. So that's already something. Eh? But I think the incentive is that we give them the benchmarking feedback. So we really show them where they can improve. And it's not only a paper that we give, but we also set up afterwards some initiatives. So we have big information meetings where we can learn from each other, where we exchange practices. And there are even further incentives or projects started, like really peer visits, that you go to a certain center and you visit how they, and follow how they act in their center. So they can benefit from it for giving the good quality of data and improve the thing. I think also important is that these data are also then, together with a group of experts, given and translated to the policymakers. So these data are also used to show, look, we are doing well, please keep investing in this system.
And do you identify the centres?
Excuse me, but I didn't...
She identifies them, but we as centers don't know who we are. We know, I know I'm number 34, 37, yeah. Something, 30 something.
In Belgium it's anonymous, but I know it in Sweden they just are open.
Yeah. But what is important for me as a center, so every 2 years when the audit is done, we get our results. And seeing where you are, like for instance, we are lousy at measuring the abdominal circumference. And so we're there. All the rest were of course top. But there we're there, and it makes me nervous, so we do rounds with the group and we show the data and we say, well, we need to do better on measuring this. And so the next years we look, do we shift a little bit? So it's, you know, that's also an incentive. It plays on your ego. Well, final question.
Yeah. My name is Giel Nijpels, and I'm a local champion from the Netherlands, and that's logical because Rob and I were collaborating with each other. But I see a serious gap in your registries because I see that the Netherlands were red, and we have a very extensive registry of more than 2.5 million people with 300,000 diabetes patients, and we even can analyze them on a person level in time. So please add that to your results. But I have one...
Can I just, before you ask your question,
yeah.
I was struck Stefano had a map with green and blue, and some country, France was gray. And then when I saw Jill's map where they had asked the ministries of health, do you have registries? Yeah. And then France became all of a sudden, you know, green. And Belgium became yellow. It was very strange. So also, what do we call a registry? Yeah. What is a registry?
How reliable is that? And my second remark is, do you look into the role of the health insurance companies? Because they are very important in giving the health. Maybe you have to combine that in your analysis. That's my remark.
Yeah. So again, Europe is very diverse with very diverse healthcare systems, and even if you say healthcare insurance, that's different. What Astrid was alluding to is the Belgian system, where everybody has health insurance, but it's organized by the government, and so the government says you have to participate in that system. Whereas in other countries, it may be different. Stefano?
Yeah, no, exactly. I mean, I think that one of the big problems in Europe is that in spite of the fact that it's a united Europe, is the different system from country to country. In some there are insurances, in others there are, you know, a healthcare system. So those is an added barrier in really achieving the implementation of a registry. Because as you can imagine, in the public health system, the need or the interpretation of the governance may be different from one where you have local insurances, you know, playing the role. So I think that we also need quite a big effort to harmonize that as well.
Excellent. So we will conclude the session. I want to thank you for attending, also the 40 people online. I do believe everybody here, being clinicians, scientists, feels that we have the need to collect data, to bring data together in quality registries so that we know what we're doing. We need WHO and us as scientific organizations to push the clinicians to achieve targets. And we need to be ambitious and put these targets perhaps a bit more ambitious than what they are, because we can achieve them. If you put the target at what you can achieve, you will never progress. So I would propose to put them a bit more ambitious. But we need to thank WHO for at least doing it and for putting it forward, and for allowing us also in Europe to make them a bit more ambitious than what we have worldwide. I would encourage each of you to continue collecting data, to please organize them in registries, and also through these registries improve care for people with diabetes. Thank you all for attending. Thank you.